बिस्मिल्लाहिर्रहमानिर्रहीम। इन्न फी इख्तिलाफिल लैली वन्नहारि वमा खलक़ल्लाहु फिस समावाति वमा खलक़ल्लाहु फिस समावाति वल अर्दि लआयातिन लिक़ौमि यत्तक़ून। ये सूरत यूनुस की आयत है। मफहूम तर्जुमा है, रात और दिन के एक दूसरे के पीछे आने जाने में और जो चीजें खुदा ने आसमान और जमीन में पैदा की हैं सब में डरने वालों के लिए निशानियां हैं। सदक़ल्लाहुल अज़ीम।
Thank you so much, Professor Salma Kundi. Professor, before starting this webinar, can you welcome the peoples at this forum, Professor Salma Kundi?
Assalamu alaikum ji. I welcome all of you on this platform in the webinar today by our great Dr. Imran Abbass, who is a famous bariatric and surgeon and a minimal invasive surgeon. And we thank Dr. Professor Mulazim Saab for arranging this. And I hope all of us gained a lot because most of us are nowadays diabetic type 2. We really want to fight this pandemic. Thank you. Over to you, Dr. Imran.
Assalamu alaikum. Bismillahirrahmanirrahim. Ji sir, first of all, really appreciable Professor Mulazim Bukhari for such an academic activities that we need review, we all of us. And when we must be aware with such treatment, then we can provide such services to our patients. Today our topic is about surgical treatment of diabetes type 2. That is a really pandemic. If we see, so nowadays obesity and diabetes is a real pandemic. And I remember in my childhood, if at that time, if someone suffered with tuberculosis, so what was at that time thinking? So now there is no treatment, but nowadays we can see how we deal with tuberculosis just like a common cold, and same how we are dealing with malignancies. So nowadays, so we must be hopeful. Yes, we can treat, we can deal with diabetes type 2 with surgery. So this was the message. So what is the agenda in our debate? Brief introduction of diabetes, metabolic basis of bariatric operations, conventional indication, emerging indications, risk stratification, and video presentation. So you know better than me, this is the reality. Unfortunately, 90 to 95% of people with diabetes have type 2, that we know. Over 25% of adult over 65 have diabetes. Exercise and weight loss reduce the risk of pre-diabetic and becoming type 2 diabetes by 58%. And how much this quality of life is effective. More than 1 in every 10 adults has diabetes. So this, and again, another, in my opinion, so what we are doing, if someone is suffering with diabetes type 2, 54% have never seen a dietitian, because so healthy lifestyle, we need dietitian. 64% have never seen an endocrinologist, just we are starting medicine with. So this is very important. 63% have never seen a certified diabetes educator. Obesity, you all know, so class 1, class 2, class 3. So, but this slide is very important. All this surgery is in this slide. If we see how we can relate obesity and diabetes, so you can see in obesity insulin resistance genes. So that is leptin. So you can see leptin receptor, PC1, POMC, MC4 receptor, insulin receptor, and PPAR gamma. So you know all better than me. And if we follow red slash, that is obesity, insulin resistance, then we can see again, so that is a orange arrow you will see, sorry, this purple. When you will see purple, beta cell dysfunction, beta cell apoptosis, impaired glucose intolerance, and type 2 diabetes. And also some, you can see here, factors also in impact on beta cell dysfunction. And if we will follow green one, then increased beta cell function, if normal beta cell, increased beta cell growth, normal glucose tolerance, compensatory hyperinsulinemia, that we call it resistance to insulin. There are a lot of studies that, so we can see, approve this. Yes, we can do surgical intervention for the treatment of diabetes type 2. So just I mentioned some of them, and also I mentioned the here our reference. So 135,000 patients underwent metabolic surgery, and mean BMI was 48. That was remission was 78%. So what mean remission? What mean improvement? Remission patient must be medicine free. And improvement we can see about all of our patients. The dose will be less. And also if patient was using insulin, now patient is using oral medicine. While like this, I will also mention how can we achieve. So this slide is again important to understand all of this surgical treatment. So if we see, we have gastric bypass. First is gastric banding. That is so not clear, but gastric band, that is in red color. Then we have gastric bypass. Then we have duodenal switch. So if you see the results at the end, resolution of type 2 diabetes, so 48% when we were doing gastric band, 48% there was a resolution of type 2, but in gastric bypass it was 84, in duodenal switch it was 98. Why this difference? If we see any type of restrictive surgery, just we reduce the size of stomach. But what is the theory of surgical treatment of type 2 diabetes is that undigested food nutrients must touch terminal ileum. So when we bypass, gastric bypass is a Roux-en-Y. This gastric bypass that they mention is Roux-en-Y gastric bypass. In Roux-en-Y gastric bypass, we make a small pouch and then we bypass a limited, not like aggressive part of jejunum, just about 100 centimeter, and it take time. But again, food will go directly to jejunum, then ileum touch L cell of ileum, but in duodenal switch. So duodenal switch is aggressive surgery. We attach ileum to part of duodenum. So we call it duodenal switch. So food will go speedy to ileum. So definite. So this is the reason in gastric band there is no bypass. Food, just we reduce the size of stomach. So food will go duodenum, jejunum, all the path, and then reach to ileum. And we can see resolution of type 2 in gastric band was less as compared to duodenal switch. where directly food, undigested nutrient will go to terminal ileum. So how does surgical treatment? We have two factors. So one is weight loss related. Yes, we all know. An obese patient, when lose weight, definite. So we will see the results. But independent to weight loss, that is more interested, because now we are talking more on this one. Someone is not obese. So how we can do? Yes, now we understand, because we understand all this function. Now we know if we will do a surgery for a patient with who is not obese. So yes, we can do. And what is the process? So impact of weight loss, we all know again: increase insulin sensitivity, decrease insulin resistance, and protect pancreatic beta cell function. But this slide is again very important. If we see, that is the hormonal changes after metabolic surgery. Now we can see here. So what will happen when we do any type of metabolic surgery? We see ghrelin hormone will decrease. Ghrelin hormone is anti-insulin and cause resistance to insulin. We can see GIP will rise, GLP-1 so rise. Also we can see PYY. When we will see any type of gastric bypass, it will increase, because the food, undigested food, touch terminal ileum. So the main role of GIP, GLP-1 and PYY we can see. And then so impact of these hormones, and we can see the result. So this is independent weight loss. We will do surgery next day. You can't believe, because I am doing. Next day, patient is still obese, and patient no need any type of medicine due to this, because same day patient pee after 2 to 3 hours. We start liquid diet for the patient, and you will see next day patient, then no need such, because if a patient was using 100 unit of insulin, now maybe need 50, because we control blood sugar. So now we will understand, this is Roux-en-Y gastric bypass, the schematic of Roux-en-Y gastric bypass. This is a small pouch. And when we will take food in this is a gastric restriction. Then we exclude this part of stomach. We will not remove. Stomach is there. So this pouch is on left gastric artery, and we will have right gastric artery, and also this duodenum and antrum, and also because if there are some secretions will come inside duodenum, we will not cut. We have stomach there. Make a small pouch, and then we attach jejunum here. Now food will come like this. So you can see, and again exclusion of proximal intestine, that this duodenum, we exclude this. Now, just I will repeat. So Professor Rubinho, he is Brazilian, and Professor Michel Garnier. In 2004, Michel Garnier from Canada, Montreal. In 2004, they were in California, and just they started. This was hypothesis of these two gentlemen. So that was foregut theory and hindgut theory. What was foregut? If we bypass duodenum, there are some hormones, secretions of hormone from duodenum that are anti-incretins. We need some incretins, and that normal incretins secretion from duodenum. Impact of those incretins on pancreas, and also for insulin production necessary. So in diabetic patients, there are some anti-incretins secretions from duodenum. When we bypass this area, because why these anti-incretin secretions when this food touch to duodenum. So we can see some anti-incretins. So when we bypass this area, then there will be no secretion, no anti-incretin, and we can see so production of insulin, and as well as sensitivity of insulin is more than a diabetic patient. So this was a theory that third that I mentioned here. Then you can see early delivery of food to terminal ileum, that is our main target. And so this delivery of partial digested nutrient to terminal ileum, and also you can see the digestive secretion from alimentary. So our small bowel, our small intestine is so largest endocrine, and then we can see the secretions. Again, I mentioned little here. So when food will come in this schematic, so this part is very important. You can see the rise from terminal ileum, rise of GLP-1, PYY, oxygen, and bile acids. Nowadays, we are talking more about bile acid and oxygen. So what is the role of oxygen? What is the role of bile acids? And in market, you can see different names like Saxenda, Victoza, Ozempic, Trulicity, and nowadays Mounjaro, Wegovy. So Mounjaro is the recent and combination of GLP-1 and GIP that naturally after this surgery, so in our body it will increase. And also again when we will do, so you can see the what will happen in liver and portal vein. All is, so these are the changes after this surgery. So I mention oxygen. If we see normal anatomy, so we can see routinely ingested air is stored in the stomach, fundus, and can be expelled through belching. So yes, we know all of this. And we know all of, so in our so gut, we have anaerobic bacteria. But after gastric bypass, what happened? So now air is inside small bowel because our small intestine is here, and we cannot expel our ingested air. So nowadays, what they did, so they take some sample of stool of these patients, and it was aerobic bacteria, and so microbiome completely changed. And this is again in favor of diabetic patients for the resolution according to, so that is the theory. Yes, when we will see, and they are just thinking about this, this is one of the function. This is our leader. GLP-1 in this surgery is our leader. If you see impact of GLP-1, so we will see impact of GLP-1 on pancreas. We can see hypertrophy of beta cell. We can see insulin secretion will be more. We can see also uptake of glucose due to high sensitivity of GLU2 receptors on skeletal muscle. And also these changes, just GLP-1. So GLP-1 is the leader. And again, you can see the main, our target, and you can see the when GLP-1 rise, impact on liver, and gluconeogenesis will be less. Glucose output will be less. So GLP-1 is very important. This is also interesting slide. And also this is the reference here, American Physiological Society. They see, especially in rats, they did this surgery, one anastomosis, gastric bypass. And also they compare what is our biliopancreatic limb. In one anastomosis gastric bypass, we make a pouch. My humble request.
Please mute yourself. Please mute yourself.
Professor Rashid Saab,
Okay, I am muting. Okay, please continue, sir. Continue, sir.
So we can see, so what is common channel, what is biliopancreatic limb? Biliopancreatic limb is part of jejunum that we bypass. So in anastomosis gastric bypass, routinely we make a long gastric pouch We also measure small bowel from DJ, from Treats ligament, about 200 centimeter we bypass, and then we attach this small bowel to gastric pouch that we make at the side of lesser curvature. That part of jejunum called biliopancreatic limb. Remaining intestine, because in remaining intestine, that is jejunum plus ileum, food will go there by biliopancreatic juice. There we call that part of small bowel common channel or common limb, just for introduction. What was their experience? If common limb, common channel is 2 meter, just because small bowel is about 7 meter to 10 meter routinely, 6, 6, 7 in Asian and in European little more, but we have 6 meter to 10 meter. That is the average small bowel. If only 2 meter ileum will be common limb, we can see more resolution of diabetes. Why? Because food will go directly, undigested nutrient will go to that area. But when we can see biliopancreatic limb is more impact on weight loss, not on diabetes. So if there is only 2 meter bilio and we can see 6 meter common channel, so then you can see, so this is reality. Why? Undigested food must touch terminal ileum. When there will be 6 meter of common channel, what will happen when food will go and reach to terminal ileum? So definite digested food. And when digested food, impact of digested food is less as compared to so undigested nutrients. This is the message in this slide. So again, that same thing that already I mentioned. So the role of our hormones. This is not only restriction. This hormonal impact is more dominant. So GLP-1 role is that I mentioned earlier, and the release of insulin, and it is anorectic. In this slide again, I repeat the role of GLP-1. What is impact of GI? This is the leader. So you can see on pancreas, insulin secretion will up, insulin synthesis, because due to hypertrophy of beta cell, proliferation beta cell, and decrease beta cell, because in diabetes, one the main issue is damage of beta cell, apoptosis of beta cell. After GLP-1 rise, this, this will be less. And we can see glucagon secretion will be less. Glucagon is also anti-insulin. And also we can see some secretions of enzymes. And same on brain, what is the impact? You can see on immune system as well. On lungs, you can see skeletal muscle uh, and all of the organs. So impact of GLP-1. GLP-1 is a leader. And when GLP-1 rise, then nephropathy. So because proteinuria will be less, and also that damage of, if in some patients due to microvascular complication. So one of the impact of GLP-1 is on a microvascular complication, and resolve this one. This is already, so we have lot of studies. If we see, this is important, compared with lean and obese control, gastric bypass patients had increased post-prandial PYY, that already I mentioned, GLP-1. And also the response of insulin will increase. This is important. So ghrelin, that hunger hormone, and also diabetogenic. So forgot theory that already I mentioned, when we anti-incretins, that secretion from duodenum, and also and suppression of ghrelin. Because what was forgot theory? So we bypass duodenum. So history of metabolic surgery. So jejunal bypass started by Richard in 1953. Then Scapinaro from Italy started duodenal switch, started biliopancreatic diversion, BPD, and duodenal switch for Marcio, and follow up. Then Michael Garnier, sleeve gastrectomy, mini gastric bypass by Robert Rutledge. And one anastomosis, Professor Carbao, he's my mentor. He's from Spanish. And Sadi, Antonio Torres is also Spanish. And ileal interposition, Surendra Ogale and the team. We can see the results also as well. I will mention CK Wang, little bit changes because our main target was low BMI patient. That was our main target. In obese patient, there is no issue. But when patient BMI is 30, so what can we do? So that is the still the challenge. Then SASI, and also I added that is staple-less SASI. I will show my video I started in 2016. So this is the schematic. So for our viewers, I put some slides because maybe some of them, they are not a surgeon. So what is duodenal switch? What is BPD? So just you can see, we make in duodenal switch, we make a wide sleeve. This is a sleeve gastrectomy. In a sleeve gastrectomy, we remove this part of the stomach. There is a long and narrow tube remain here. And again, we cut D1, we staple here, and we attach ileum to duodenum. This is duodenal switch. We make a wide pouch of a sleeve and then attach ileum to duodenum. And again, there is a jejunal-ileostomy attachment. So this part is bypassed. What mean bypassed? Food will not go inside this, but biliopancreatic juice is here. Biliopancreatic juice without food will come and then attach to ileum and then food digestion. So what will happen? Food will go directly to ileum, attach to terminal cell, that L cell, and rise of GLP-1. In biliopancreatic diversion, we make a small pouch of stomach. Here we make a sleeve, completely we make a sleeve, but here no, just we staple this area like this, and then other same like this. So BPD and duodenal switch difference is this. In duodenal switch, we make a sleeve, duodenoileostomy, but in BPD, just gastroileostomy. This is the difference. So this is a sleeve gastrectomy. So standard sleeve, we remove about 80% of stomach in a sleeve, and just this part remain here. This is mini gastric bypass. What we make a small pouch here. So on left gastric, just we start below crow foot and we make a small pouch, and then we attach jejunum about 200 centimeter from DJ to this part. Now food will come. There is some restriction and food will come inside jejunum. We call it mini gastric bypass, but stomach is here. We will not remove the part of stomach. In Roux-en-Y gastric bypass, we make again a small pouch. In mini, our pouch is longer and size is bigger. But in Roux-en-Y gastric bypass, just make a small pouch and then we attach jejunum here and also this jejunum to ileum or jejunum to jejunum. This is called Roux-en-Y. This was changes by C.K. Huang, especially for low BMI. What he did, so this is just like you can see a wide sleeve, then staple duodenum D1 and attach jejunum 200 centimeter loop to duodenum. A little like mini, but difference is this. So attached to duodenum, not to stomach. In stomach, in mini, we make a pouch. We will not remove this part of stomach. This is ileal interposition. again they think, so when we will do such a surgery, patient will lose weight, patient already a low BMI patient will not tolerate mini gastric bypass, will not tolerate Roux-en-Y, will not tolerate BPD, duodenal switch, that are aggressive surgeries for weight loss. So then they think about this, and Dipala, Professor Dipala from Brazil, and they think, so what we do, we can do ileal interposition. We can take ileum about 170 centimeter, and also we can bring just near to our upper part of jejunum and jejunum to ileum. That was amazing, because in such a surgery, patient will not lose weight because there is no bypass in this surgery. But now ileum is just near to duodenum. So what will happen? Then food will touch undigested nutrient, because ileum is now near to stomach, and we will see the results. And I remember in December I was in Belgium, and one of the professor from Harvard University, Professor Scott Ashkur, I asked him, so now we are doing aggressive surgeries. Are you thinking about in your university about any trigger to stimulate these L cell? If we can stimulate L cell, then GLP-1 will rise, and then no need any surgery. He asked, yes, we are doing. And in near future, we will see, and maybe in near future, then there is no need such an aggressive surgeries. So this is one anastomosis, gastric bypass by carbo, just like mini gastric bypass. This is Sadi. So just I put some pictures for more understanding. And so this is that I changed in 2016 because we always think about cost effectiveness. Our patient has some issues definite. In Pakistan, India, we have such a situation. So because the main so expenses is due to stapler. Stapler very expensive. Just one stapler, imagine, is about, in Pakistan, I am asking, about 30,000 rupees. And that is disposable, and we need at least 7 to 8 stapler for each patient. And also there is a gun, we call it gun for stapling, ligasure. So these are expensive, just expenses, and this disposable about 300,000 to 400,000 rupees, just expenses of these disposables. And then we will go anesthesia and hospital and surgeon fee, and that is in Dubai more expensive. In Dubai that we are taking, and also surgery is expensive. And due to this, what I think about this, what I am doing for low BMI diabetic patient, I never use stapler, just with stitches. I attach small bowel to antrum and plicate the stomach, reduce the size of fundus just with stitching. Just I use 2 or 3 prolin, and amazing result. There is no stapler. Just imagine I can decrease about 400,000 rupees for each patient, and I am doing. And alhamdulillah, I will show also my results. That already we discussed about our gut hormones. This is also changes that confirmed after these surgeries. These are also from Rubinio, and also how can we see the changes, anti-incretins and Rubinio and Michel Garnier. These are also as well, because already we talked about this role of GLP-1 and other hormones. So this was the that already I mentioned foregut theory. What is the foregut theory, and also as well as what is the hindgut theory, when food will go our nutrient will go to distal bowel and rise up GLP-1, then trigger L cells. So there are clinical implications. You can see NIH system, NHS system, their indications, everything I mentioned. Nowadays, if someone know about this, definite in US and UK, metabolic surgery is covered by insurance, because they can see if we will do just 1 hour surgery, and you can compare with the patient, diabetic patient need more and more expenses. In India, because Indian population is different overall in India, so we can see definition of obesity is different. So overweight start BMI 23 and obese 25 in Indian population. Their height is less, and central obese. Our main issue is central obesity in diabetes. Due to this, so indication is in BMI, low BMI in India. So also there are lot of these reference that I mention here. So we have, again, you can see now they change little in NIH system. If BMI is, patient is obese, no need to go for lifestyle changes, just go straight for surgery, because in such a patient, lifestyle change is not effective. If patient is morbid obese, so they change till, if you can see, individual with BMI 30 to 35. Now this is the new guideline of NIH system. Before this it was 35 plus, but now they are asking about BMI 30 is, yes, you can go, and you can, there, this is beneficiary. You can see all of, like, if so, like ASMBS, ACS, American College of Surgeon, all of these organization you can see, and their recognition for metabolic surgery. Same in European guideline, you can see in Dubai that I am practicing. So obese patient without any comorbidity, BMI plus 40 plus. We have 20 comorbidities, and one of the comorbidity is quality of life. How you can define quality of life? We cannot define. Definite, all of patients are suffering with quality of life. And also BMI 35 plus and one comorbidity, like just knee pain, back pain, quality of life, diabetes, hypertension, epilepidemia. So 20 comorbidities. And also BMI 30 plus 2. And it means if patient is diabetic, definite patient has 2 comorbidity, and we can do surgery. So some results of my, that is limited cases, only gastric plication with ileal bypass, all is step-less that I did. Total patient that I am following with this new technique is 56, male patient 19, female 37, and mean age was about 39, BMI was 36, because low BMI, 30 to 40 about. And this was operated time. Weight loss was less because our target was not weight loss. And diabetes period was in this patient 8 plus years. So if you see here, this was interesting. So this FBS was 183, and you can see the process of 12 months, now 86. Again, one thing that was also interesting for me, C-peptide, because selection of patient is very important. We must check fasting C-peptide, fasting insulin, serum insulin, and then also we must rule out LADA, any type of autoimmune impact in low BMI, because we must check C-peptide. And if C-peptide is about 40% that beta cell reservoir, we can go ahead. Till 30% reservoir, we can go and excellent results. So preoperative was 1.9, and it increased. Why increased? Due to hypertrophy of beta cell. And it was amazing. Just now also I had a patient from Larkana, Sindh, and I did surgery about 1 year. And when he, because every month, last week of every month, about I am in Pakistan, in Islamabad Advanced International, and routinely I am doing their metabolic surgery. It was amazing. He was using about 100 units of insulin. Now he's not taking till pills. And his C-peptide was double as before surgery and now, due to hypertrophy of beta cell. And you can improvement also as well, other elements, and also because most of our patients are suffering with fatty liver, so ALT, GGT was rise, and with the passage of time decrease, that we all know about this. And another interesting thing, because when we do any type of surgery that is like mini gastric bypass, that is a hypoabsorptive surgery, we see more micronutrient deficiency. But in this surgery, because this is not weight loss surgery, This is just metabolic surgery because we have duodenum path as well. Just we attach jejunum to antrum, we can see, and all of these patients were taking multivitamins. They were taking like other patients. But in other patients like mini gastric bypass, we see iron deficiency. Routinely, we see calcium deficiency. We see rise of PTH due to bone hunger and secondary hyperpara. But in these cases, they were using same multivitamins like other patients. But this was amazing. So we would not found any type of micronutrient deficiency till iron. You can see they were using multivitamins like other patients. This slide especially is for my youngsters because overall this presentation is routinely for my youngster target. So if you are going to do surgery, you must know about risk stratification. And if you will not know, then there will be disaster. If patient is BMI more than 50, male gender, hypertension, risk of pulmonary embolism, and age 45. So if you score, you can see if score is 4 to 5, so then you can see mortality is about 7%. Due to this, if you are going to do this surgery, must be in tertiary hospital. Someone must do who is eligible to do this surgery. Unfortunately, in Pakistan, there is little control, but we must have some guidelines. Also in this adverse, so that I mention here. So how can we decrease? So liver reduction diet. So we must prepare the patient, then we can do surgery. Smoking cessation, intragastric balloon. If patient is weight is 200 kg, 150 kg, then we must reduce 15 to 30 kg. Then liver will shrink and it's easy. Staged operation we can do. And this is how can we counsel our patients. Conclusion, intestinal rearrangement promotes powerful hormonal alteration. So paradigm shift, GI surgery as frontline treatment for type 2 diabetes and pre-operative risk stratification is critical preparation for metabolic surgery. So this is that technique that I mentioned for you, how now I am doing stapleless without using stapler, how I am doing metabolic surgery. So in short video, you can see here. So this is our stomach and you can see our momentum, and this is great curvature with ligature. This is a ligature that I am using. With ligature, just we cut, we do hemostasis and then cut. And this is antrum, this is pylorus. Just near to pylorus, we will do gastrolysis. Then now I am doing this gastrolysis of greater curvature. This is our liver. And with this grasper, so we do retraction of our grasper. Here is a spleen. I will show you. Just now you can see gastrolysis of greater curvature just with ligature. Then I will go for jejunum. I will measure, yeah, maybe ileum. Yes, I am measuring ileum from ileocecal valve. So this will be standard stapleless SASI. What is SASI? This is single anastomosis, sleeve ileal bypass. So I am measuring ileum about 300 centimeter, 350. It depends on the BMI of the patient. Then I will confirm that loop and I will attach here. Just you can see I will attach here with antrum just near to pylorus. I will attach ileum here. All is hand sewn. There is no use of stapler. So this is cost-effective surgery. I started in 2016. And also I presented my videos in Oxford University, in Germany, in Spain, in all of our conferences. In London till 2017, there was a IFSO meeting. So this is especially these our countries where, so this is our antrum. I am making gastrotomy. Then I will do gastroileostomy. I will attach. All is, again I mention, is without stapler. Just I am using L hook. With L hook I make a gastrotomy. Then we push our anesthesia. We'll push tube. Now this is the gastric tube here. It's easy to make a gastrotomy. I will make the gastrotomy here. That is easy to do when you put your gastric tube inside and push. Now you can see just with this, now I am using this PDS. PDS is absorbable suture. When we are doing any type of gastrojejunostomy or any type of anastomosis, we always use absorbable suture. Because if we will use proline or nylon, there is more chance of marginal ulcer. So now you can see here, I attached this loop to this ileum loop to antrum. Now food will also go to duodenum as well. And also some part of undigested will go to ileum. And that small part of undigested food when touched to ileum and L cell, then we can see increase of GLP-1 and we can see the result. And now I am also making this gastric plication. I am not using any type of stapler, just with proline. For gastric plication, always we use this proline. And this is interesting that I must mention, because we must mention gastric plication was started by Professor Talebpour. He is an Iranian professor. He started this technique in 2000, about 22 years ago, because due to sanction, American, at that time, stapler was only by American companies like Ethicon, Echelon, and Covadian. And due to sanction, so they sanctioned Iran, and also they asked them, so we will not give you these staplers. So what they did, Talebpour think about this. So because their population is obese at that time, also obese, he think about this. What can I do? And he started plication at that time. And now you can't believe this technique is also approved by ASMBS, FDA approved, if so approved. Now Brazilian, Mexico, till American, all of them, they are doing this. This is cost effective as well. And started by Professor Talebpour. Just I added that loop after this metabolic surgery. But this plication was started by Talebpour about 24 years ago. And I added that loop, that is a gastro or enteroileostomy. And just now you can see the beauty of this plication. We make this tube without using any stapler, and also enteroileostomy, and we can take the result within days. You can't believe, within days there is no diabetes. And within days, because we will see the rise of GLP-1, and patient will not lose weight because already food will go from duodenum. We have all of that passage as well. And this one, next one I will show you. This is one anastomosis gastric bypass that routinely I am doing this for my obese patient and also diabetic patient. And this technique directly I learned from Professor Carbajo. Professor Carbajo, he is a Spanish professor, and he started this technique in 2002. And I was lucky to take this opportunity to learn from the pioneer of this type of surgery, just with using this, we call it optical trocar, because patients are obese. Now I am entering inside the abdomen. You can see anatomy and how I retract the liver, huge liver. So this is due to when patients are diabetic. So there is fat deposition. You can see fatty liver, huge liver. This is left lobe, huge liver, and just I retract. And then I will do, there are some adhesions. And this is just, you can see his angle near to EG junction. There is a spleen as well. You can see this is esophagus. This is EG junction. Here is EG junction. This is left crus. We have a spleen here. We will do here this some dissection. We do adhesionalize. And then I will make a windows, you can see the momentum. We can see this thick momentum. Always we face such a situation in diabetic patients. Thick mesentery, thick momentum, they are central obese. And this momentum and thick mesentery cause resistance to insulin. And then we make a window here in this small sac we make here. This is small momentum, and we will go here. And this is the, you can see lesser curvature. Here is pylorus. We make a window here for our first stapler, and we will make a, just I will show you how I do. This is my, now this is first stapler. This is stapler. So what is the role of stapler? Stapler hold the tissue, then staple, and then cut. You will see there will be till no RBC, no bleeding. Just with 3 line, you can see just with stapler how we do stapling, because first surgery was without stapler. This is with stapler, that is one anastomosis, gastric bypass, and I am making a small pouch on lesser curvature. This is my lesser curvature on left gastric, and I never remove our that part of fundus and body, and because blood supply from right gastric already there, this stomach will be inside stomach, there is no issue. And this is also reversible surgery because we will not remove. And just now you can see I am making a small and this narrow and long pouch. Then I will attach small intestine, because when we will cut, this is my last window that I will staple my last stapler here. And just for our viewers, so you can see here, yes, now I will go, I will do that. That is my window here. Everything is clear. Now I will staple my last stapler that I am using here. This is Covadian or Medtronic nowadays, and also a definite American and excellent product. And now we will go for, yes, everything is okay and completely cut. And this is my stomach pouch. I will make a gastrotomy here with harmonic. This is harmonic that I am using now. We call it harmonic. We also use ligature for our hemostasis. And I hold my tissue with my left hand. I will make, there is a gastric tube inside. Now I will measure from DJ. In previous surgery, I started from ileocecal, but here I will start from DJ. This is my tritz ligament, and I will measure about 200 centimeter of jejunum. And then I will attach to that gastric pouch. This is my DJ. This is my small bowel. You can see, and I will measure just with clockwise like this. I will measure this one because we need that esoperistaltic movement. And I will do enterotomy here, and then I will do gastrojejunostomy with stapler. This is my enterotomy, and then I will put my stapler inside, and I will attach my this jejunum to stomach, and that will be gastrojejunostomy. Just a minute, this will be, you can see here, that is also just, I will bring now my stapler, and we routinely use here blue because there are different colors of staplers, and routinely here we use blue stapler. This is my intestine, and now I will show you my stomach pouch. I will attach my intestine to stomach pouch here. Yes, now you can see how I did this. Yes, stomach, and this is my intestine. Just I attach this one, and then I repair that. So this is my hospital that I am working in Dubai. Anytime, highly welcome, sir. Sir, if any question?
I hope we'll answer reply at the end when you complete it.
Sir, complete, finish.
Okay, thank you so much. Thank you so much. Now it is open, session is open for the questions, and very important questions, Professor Rafiq Kanani. Can you address Dr. Imran directly? Preoperative assessment guidance and the post-operative. Same as my questions, complication, short term and long term.
Sir, pre-operative.
Thank you very much.
Sir, please.
GG, Professor Kanani, you open the mic and you can ask.
Yeah. So, Dr. Imran, excellent presentation. In fact, I've tried to learn about this surgeries, but nobody explained it to me the way you have done it. So I'm really grateful to you. My questions are that number one, what pre-operative preparations are required in such cases? Secondly, the post-operative complications and the recovery period, so that the client is prepared for it. So short-term and long-term complications as well. Thank you.
Sir, first of all, so much thanks for your nice comment. I am also practicing in Islamabad in Advanced International Hospital in G8 Markaz. And every month, last week, routinely, every month I am there. In Dubai, yes, I am practicing here as well. In Lahore also sometime I am there in Sharif City Hospital and Umar Hospital as well. Sir, so the main, how we select patient selection, that is very important, and preparation. Patient selection is very important in diabetic patient. If patient is low BMI, because in low BMI we can see LADA, that is 1.5, that is not type 2, that is not type 1, that is type 1.5, that is LADA. That is, so we can see autoimmune impact. We must rule out in this patient. We must see the beta cell reservoir that we can check with C-peptide. How we check? We take fasting C-peptide, then so after taking some food, again we check and we will see the increase of C-peptide. If C-peptide increased, so we can see the increase, it means there is impact, still we have reservoir of beta cell. So if you see routinely, so our, you all know because you pathologists know better than me, C-peptide. So normal range is about 4.4 nanogram or about 5. That is the standard in the world. If we have 2 C-peptide, it's amazing. Then 30%, 40% of my beta cell reservoir is, so we have, and we can go for surgery till 1.5. We can take the risk, we can talk with the patient. But if less than 1, then there is less chance of result because we don't have beta cell reservoir. And next one is serum insulin. We must see how much serum insulin production. If very low, then there will be less chance of response. We must rule out antibody. We do islet cell antibody, GAD65. We must check, and we see in low BMI. I am talking about low BMI patients. And then we must consult the patient. We talk with the patient. So what is the remission? What is improvement? Then, and also if patient is just like imagine 20 years now suffering with diabetes, we must rule out nephropathy. We must rule out retinopathy in these patients. And it's amazing. I personally was witness many of patients that already using stent due to so this coronary artery and also atherosclerosis. After this surgery, there were floating stents, and this terminology started by I forget the name of that professor. Floating stent after metabolic surgery, and there are a lot of articles about this. What is the risk? This is a good question. This that I am talking about. Now, just risk, surgery risk is like lab coli. If someone is doing who has expertise of this surgery, because now we have 4K laparoscope. 4K means you can see 16 times more than naked eye. So there is no chance of bleeding if you use standard instrument. If you will go a standard team, there is no risk, just like lab coli. But long term, yes, if you see, it depends on again surgery. Short term, as I mentioned, there is very less than 1% chance of bleeding, less than 1% chance of leak, because this is practically, so if you will go a standard technique, expertise surgeon, tertiary hospital, there is 99% you will go safe. Long term, yes, if we will go for bariatric surgery or weight loss surgery, that is hypoabsorptive surgery, be careful, especially micronutrient deficiencies, especially calcium, B12, and also iron deficiency. But for low BMI, because we are not doing such an aggressive hypoabsorptive surgeries, there is less chance of micronutrient deficiency. One thing that we must be careful regarding marginal ulcer, because when we'll do any type of gastrojejunostomy or gastroileostomy, always we prescribe PPI for our patient to decrease acid production. Then there is smoking is not good in these patients. They must quit smoking, and also NSAIDs if someone is suffering with so because NSAID is also cause marginal ulcer. So we must always in touch follow our patients. These patients are lifelong follow-up. This is not just like hernia or lap chole patient we didn't finish. No, we must follow. Then there is less chance of any type of complication.
Thank you, Dr. Imran. I was last week in Iran, and I visited Iran University of Medical Sciences. And there I met the youngest bariatric surgeon, Yari Kuli. She knows you, and most of the team were there. And it was amazing that most of the countries from outside, they are not going in America. They are going to learn such type of technique in Iran, especially in the Iran University of Medical Sciences. And thank you so much. If such a nice presentation, we are proud of this. As a Pakistani, you are doing a lot of things. My question is that, is there any technique that without surgery, we can reduce these hormones?
Sir, still that was that I mentioned. So in December, I was in Belgium. Yes, they are working on it nowadays. And as Professor Scott Shkura, and I remember I mentioned him, sir, then you will take Nobel Prize and just in a light mood. And he asked me, I will also share with you. So
Okay.
this is, yes, they are working on it. So, and this is our also dream. So we must see how we can trigger that L cell, and also we can increase production of GLP-1, then no need to go for such a aggressive
Yes.
surgery and process and complication. But in this era that we are sitting here in 2024, maybe after one decade, we will talk, oh my God, what were we doing at that time? No need such an aggressive surgeries. But now, yes, if we see, and personally, I have witnessed lot of my patients who were suffering with nephropathy, just going to dialysis, now no need. And now patients without, they are really diabetic free. There is no diabetes in these patients, and they are enjoying, they are medicine free. Hundreds of cases, personally I did, and I am witness. In this era, yes, I can see this is the effective.
In last lecture, we discussed and you gave a list of diet, especially about our weight. And
Yeah.
about our wheat that we are using nowadays everywhere. I advise all these things in few of the diabetic patients. And one of my class fellow, he used such thing. He totally went out from the wheat and adopted another. He is feeling better. Things I think. Is there any correlation of this wheat with these hormones?
Sir, definite. So wheat is the main, I think, our culprit is wheat. So now if you
Yes.
see our ahadith pember, and so you can see always barley, jaw, not wheat. Unfortunately, wheat is glucose, that is not complex carb. And also there is gluten, and gluten also, this is, so you can see that damage beta cell. So when we delete wheat from our food and as well as rice, so then amazing results. Personally, I have many patients. Always I suggest my patient go for healthy lifestyle. I never suggest him first surgery. And healthy lifestyle top is diet and physical activity. In physical activity, walk and swim. Walking and swimming. If you are going to gym, no need to go aggressive. Okay, if you can do, and in your diet, wheat free. I remember maybe last time I mentioned or not, because I am also fellow of American Society for Metabolic. Every year we are there in US, and I was there in Texas in Centennial last year in our meeting, and one of our session was metabolic surgery and diet. And now American are going to go for bakery product, wheat free and barley. This was amazing. And another thing that I was witness there, one of Japanese, as he informed us in that session, now Japan is wheat free. And so you can see he show us the graph. Now drop diabetic patient, definite. This wheat is not increase that GLP-1, but decrease that apoptosis of beta cell, damage of beta cell, and also this is glucose pure. If you see, barley is complex carb, and so due to this we always prefer to take barley, multigrain, so not wheat, so effective. I think professor also has any question, someone.
Dr. Rafiq Kanani, another question, sir.
No, that's not a question, it's a comment. A number of friends I made and I was unable to recognize after their surgery. So I will endorse whatever Dr. Imran has presented. And I think that several people I met, they have improved a lot. They are free of diabetes. They are free of nephropathy. And I think that just like cardiac bypass and stent surgery, this should be made the standard of care for those who are really in need of this surgery. Thank you.
I agree, sir. Thank you, sir.
Yes, right. Any other question? Dr. Rashid, you always ask the questions. Dr. Rashid?
सॉरी सर, इस दफा सर्जरी चूंकि फील्ड है तो सर्जरी में
असल में सवाल ये है कि शुगर को कम करना है।
हाँ, शुगर को कम करना है सर, बिल्कुल।
डॉक्टर इमरान, अनदर क्वेश्चन फ्रॉम मी, क्योंकि ये पिछले दफा हुए थे, क्या सिर्फ ओबीस पेशेंट ना हो जो और डायबिटिक हो, क्या वो भी इस सर्जरी के प्रोसेस से गुजर के अपनी डायबिटीज को कंट्रोल कर सकते हैं?
सर, जो क्राइटेरिया हमारा जो इफ्सो गाइडलाइन है, हमने हमेशा जो भी काम करते हैं तो अपनी इंटरनेशनल गाइडलाइन को फॉलो करते हुए हम करते हैं। इफ्सो गाइडलाइन में जो एशियन पीपल है, BMI 27.5 ये हमारा स्टैंडर्ड है। अगर BMI 27 प्लस है, वी कैन गो फॉर सर्जरी। दैट आर नॉट ओबीस, 27 you know is overweight, we can do surgery, yes. But if BMI is less than 27, be careful. The most people are autoimmune impact, they are not type 2, and then we will stuck. तो इसलिए हमें बड़ी केयर करनी होती है पेशेंट सिलेक्शन में। पेशेंट की BMI 27 प्लस हम रिलैक्स करते हैं, ये इंटरनेशनल गाइडलाइन भी है, हमें कोई मसला नहीं है। लेकिन अगर उससे नीचे हो, मैंने 25 का भी किया है, रिजल्ट भी लिया है, लेकिन बहुत केयर की, उसके सारे टेस्ट किए, ऑटोइम्यून इम्पैक्ट को रूल आउट किया। पेशेंट से बात की, वो आए थे कतर से और उनका ऑपरेशन भी मैंने लाहौर में किया था, तो मैंने उनके साथ आज से 1 साल बड़ी डिस्कस करके ओरिएंटेड, उसको सब कुछ पता था। उसकी मिसेज भी थी, मिसेज का BMI 30 प्लस था, उसका 25, लेकिन अल्हम्दुलिल्लाह ही इज़ फाइन। और अभी 3-4 साल हो गए, और उस टाइम उसका नेफ्रोपैथी वो था, और साथ ही स्टेंट का ही वाज कैंडिडेट एट दैट टाइम, आई रिमेम्बर। तो लेकिन उसका जो एजेक्शन फ्रैक्शन भी 30 प्लस ऐसे ही था। हमारे कार्डियोलॉजिस्ट ने ओके दिया, हमने ICU प्रिपेयर किया, ये सारे रिस्क लिए, लेकिन अल्हम्दुलिल्लाह बड़ा स्मूथली सर्जरी गई। एंड नाउ ही इज, वो अभी भी यूज करता है मेडिसन, क्योंकि जब भी बीटा उसका 0.8 था सी पेप्टाइड, तो जब 0.8 था, मैंने सारा, उसने कहा मुझे सब पता है, मुझे जस्ट इम्प्रूवमेंट चाहिए, क्योंकि ऑलरेडी कतर में हो रही है ये सर्जरी। तो पेशेंट सिलेक्शन, yes, we can go.
Professor Salma Gundi, you want to ask the questions?
हाँ जी, सर्जरी का वैसे ही नाम सुन के बहुत लोगों को डर लग जाता है, तो I only wanted to ask Dr. Imran साहब कि कितना % weight reduction and over how much time is mandatory, which can save you from bariatric or weight loss surgeries or whatever surgery you're doing at the moment?
So your question in two parts. One is related to weight loss surgery, just weight loss. If we are talking about weight loss surgery, not
No.
diabetes, so I am
No,
just my
weight loss surgery, which takes care of diabetes as well.
so no, just I am
क्योंकि
yes.
200
इसको मैं दो हिस्सों में तकसीम कर देता हूँ कि
कर दें
वेट
जी।
लॉस कैसे होता है और डायबिटीज। अगर जस्ट इमेजिन करें पेशेंट का वेट है 150, 120, 130, 200, तो जब पेशेंट का वेट ज्यादा होता है उसकी जो डायबिटीज है वो विद इन डेज ठीक हो जाती है। अभी वेट उसका कोई रिलेशन ही नहीं है वेट लॉस से डायबिटीज का, वो तो हार्मोनल इम्पैक्ट है ना। वो तो आप नेक्स्ट डे आप देखेंगे उसका इम्पैक्ट विद इन वीक, मैक्सिमम 3 वीक्स में पेशेंट मेडिसिन फ्री हो जाएगा। स्टिल पेशेंट इज ओबीस, लेकिन उसका वेट लॉस पे टाइम लगता है। हमारा ये होता है कि जो एक्सेस बॉडी वेट है, यानी अगर पेशेंट का आइडियल बॉडी वेट 90 होना चाहिए आइडियल बॉडी वेट, और अभी 150 है, इट मीन 60 इज एक्सेस बॉडी वेट। तो फर्स्ट 6 मंथ में उसे 30 kg लूज करना चाहिए, ये स्टैंडर्ड है। अगर इससे ज्यादा स्पीडी करेगा तो उसके लिवर पे इम्पेक्ट होगा। तो हमारी ये कोशिश होती है, पेशेंट को एक डाइट प्रोटोकॉल हम देते हैं कि आपने ये फूड लेनी है, इस तरह लेनी है, मील लेना है, ताकि वो उसका वेट लॉस स्पीडी ना हो। तो फर्स्ट 6 मंथ में 50% एक्सेस बॉडी वेट, नेक्स्ट 1 ईयर में, क्योंकि हमारा टारगेट होता है 1.5 ईयर में वो अपना वो जो टारगेट है एक्सेस बॉडी वेट यानी वो 60 kg को 1.5 ईयर में उसका वो लूज होना चाहिए। लेकिन जो डायबिटिक वो तो विद इन डेज वो पेशेंट जो है मेडिसिन फ्री, क्योंकि उसका हार्मोनल इम्पैक्ट है, उसका कोई वेट से रिलेशन नहीं है। लेकिन लॉन्ग टाइम जब हम देखते हैं कि इसका पेशेंट विल रिमेन डायबिटिक फ्री, वो फिर वेट लॉस की वजह से होता है, क्योंकि साथ वेट लॉस भी उसके लिए एक पॉजिटिव इम्पैक्ट आता है।
ये
थैंक यू सो मच।
अपना ये एक क्वेश्चन है, ये हमारी टीम थी पिछली दफ़ा हम गए थे, तो उसमें आपकी वो डॉक्टर यारी कुली को दिखाना चाहता था।
जी सर।
ये बैरियाटिक सर्जन है, ये वाली।
सर
तो
बुखारी साहब डबल क्लिक कर देंगे, अभी वो शो नहीं हुआ, सिर्फ फोल्डर शो हो रहा था।
शो नहीं हुआ, मैं इसको देखना चाहता हूँ, पता नहीं क्यों नहीं हो रही। हुआ
एक
है।
और क्वेश्चन भी है।
जी
अच्छा
सर अब
माशा।
शो हो गया।
ये हो गया,
फिर
ये डॉक्टर बैरिक,
फिर-
ये मेरा ख्याल ये है, ये यंगेस्ट सर्जन। एंड आप, हमने बड़ा जोक भी किया कि माशाल्लाह आप इतनी कम वजन है और बड़े बड़े लोगों का वजन ठीक करती हैं। ओके। ओके, अच्छा, जी डॉक्टर शमसुद्दीन, यू हैव द क्वेश्चंस। जी डॉक्टर शमसुद्दीन, यू हैव द क्वेश्चन। Okay, another person you have
Assalamualaikum sir.
V20 for and you can ask the question.
Yes sir. Assalamualaikum sir.
वालेकुम
जी जी।
Sir, I have a question from Dr. Imran Abbas. Sir, very nice presentation, mashallah. Sir, the surgeries you have performed without stapler, the most common complication you presented in this patient. Can you share this about?
In stapleless, when we are not using a stapler, there is no chance of bleeding because the bleeding is due to stapler. When we cut, we are not cutting stomach, and also there is no leak because we are not cutting. So the yes, one question that is, if you will not do proper plication, standard plication, there is chance of obstruction of stomach, because we when we are doing plication we must do standard, we must follow that standard rules. Then there is no chance. The main that your question is this, yes, if someone is doing who has not expertise, because plication is very difficult, because overall intracorporeal suturing is very difficult, that if someone surgeon, so they know intracorporeal suturing is very difficult. And when we are doing plicating all the stomach, so then be careful, we take 3 4 layers. And also
Right,
our
sir.
first stitch is like door fundoplication, just we
Ve-
plicate like this. If we will not do, we push inside, there will be chance of obstruction and herniation of this mucosa inside esophagus. And so definite this is the main complication of plication. But
Right
otherwise,
sir।
because we are not cutting, there is no bleeding, no leak, because we are not cutting, just we are stitching.
Right, sir. Thank you, sir.
Dr.
Thank
Imran,
you.
how you reduce this complication of herniation and obstruction?
Sir, it is expertise technique. Personally, if I see, I faced at initial stages. Yes, I faced, because if some surgeon is asking, I have no complication. There are only two. He is not doing surgery, as he is not unfortunate. He is lying. Yes, faced, but we learn with the passage of time. Again, I discussed with Professor Talipur. So I have this issue, how I do stitch, how like this. Then with the passage of time, I learn. Yes, so when I am doing this, I must be careful at this stage, how I take the tissue, how I do this plication. And if you, maybe you know, due to sanction also, Iran could not take Da Vinci, that is a robot. And now they make their own robot, that is Sina robot. Maybe you know
Yes, yes,
about
yes.
this. And now they are doing their surgeries with robotic surgery with their own robot, and that is a seen and amazing results. So we were together 2 weeks ago in Beirut, in Lebanon, in a conference, and also I was talking with Professor Talipur and about my this technique and different things. And so again, we are talking about Sina robot, how Sina robot is doing, and amazing results, sir.
Thank you very much, Dr. Imran. I think the time is almost 1.5, 1 and 15 minutes. And Professor Salma Gundi, I think there are so many questions, but this was an excellent presentation. One more thing is today, some of our experts, professor from Islamabad, Quaid-e-Azam University from Islamabad alumni here, we welcome, especially Professor Syed Azim and his team. Welcome, Dr. Syed Azim, in this forum. Hopefully, this forum, today's discussion will be helpful for all. Dr. Salma Kundi, can you conclude today's session? Thank you so much.
Thank you, Professor Mulazim Saab. It was such a pleasure listening to Dr. Imran Abbasi Saab. It was a great talk. Thank you so much, Dr. Imran, for giving us your time, especially on a weekend. And we hope to see you sometime in Lahore. And I'll send you patients, inshallah, because I've got many obese relatives with diabetes type 2. And I hope all of us benefit. But a healthy lifestyle, diet control, and walk is also mandatory. Pakistan Zindabad. Thank you.
Thank you so much.
Allah Hafiz.
See you, inshallah, next week. Thank you so much.
Inshallah.
That's